Sorry, Club. I'm Dr. Chuck with CMAC. So today I want to continue with Med Tutor. And most of you know that I like to do medical tutor in the English language, since English language is the universal language of medical education. And I hope my videos have helped some of you guys, especially you guys who are studying for your various board exams. Keep on working your concepts, keep on doing questions. Do as many questions you can. Go through your Q banks 2 or 3 times. Seeing same questions asked a different way will help you consolidate your medical knowledge more and more. And as I said in past, medical education is not about how smart you are. It's more about knowing how to study, being disciplined, repetition. All these things will help you bring what you've learned into your long-term memory. So today, I'd like to begin tutoring about the 12 pairs of cranial nerves. So we're going to go slowly. So the next few Med Tutor videos will be dedicated to cranial nerves. And I'm going to highlight what they like to ask on the board exams. I'm going to highlight the clinical relevance and the concept they like to test on the USMLEs. So cranial nerves, what are they? Cranial nerves are the nerves that emerges from your brain directly, right? And it exits your skull and are involved with motor function and sensory of your head and neck mainly. I'll give you an example. Cranial nerve 7. What is cranial nerve 7? Cranial nerve 7 is facial nerve, right? And one of the functions of facial nerve is motor function. It's involved with facial expression. You smile, you frown. That's from the facial nerve. So the facial nerve emerges from the brain directly, and it exits your skull through a foramen. That foramen is called the stylomastoid foramen, and basically your brain will send a signal, will send like electrical impulse through your facial nerve, telling your facial nerve to smile, telling you to smile, and that facial nerve will contract your facial muscle in a certain way that makes you smile, right? And also cranial nerve will send signal from the outside back to your brain also, and I'll give you an example of that. Example of that is maybe cranial nerve 5, trigeminal nerve, right? Trigeminal nerve involved with the sensation of your face. So when the doctor touches your face with a cotton or brush your face with Q-tip, that stimuli travels through branches of your trigeminal nerve back to your brain, and it's telling your brain now that the doctor's touching your face with a Q-tip. So in a sense, cranial nerve kind of like relays message from your brain between your brain and your head and neck, and it could be sensory message or it can be motor message. So all of the cranial nerve mainly stay within the head and neck region except for one. One cranial nerve that leaves the head and neck region is cranial nerve 10, the vagus nerve. So the vagus nerve kind of involved with the parasympathetic innervation like throughout the body. So and also the smooth muscle, the glands, the lungs, the heart, the abdomen, it's all vagus nerve. So the vagus nerve does leave the head and neck, but usually all other cranial nerves stays within the head and neck region. And cranial nerves are different from spinal nerve, right? Spinal nerve are the nerves that kind of like, you have to go through your spinal cord when the brain orders you to do something. Let's say the brain's telling me now to move my right arm, right? To put my right hand up like that. It has to send a signal from the brain through my spinal cord, and then from the spinal cord, it's gonna tell my brachial plexus to hold up my hand. So it has to go. The signal has to go through the spine and then to peripheral nerve to the brachial plexus. That's spinal. That's example of like spinal nerve, right? Whereas the cranial nerve, it doesn't have to go through the spine. The cranial nerve just goes from your brain through your head and neck directly without going through the spinal nerve. So that's one of the differences between cranial nerve and the spinal nerve. Cranial nerve emerges from the brain directly and deals mainly with the head and neck region. And we have 12 pairs of them. What are they? First nerve, cranial nerve 1 is what? It's olfactory. Number 2 is optic nerve. Number 3, oculomotor. 4 is trochlear. 5 is trigeminal nerve. 6 is abducens nerve. 7th nerve is facial nerve. 8th nerve is vestibulocochlear. 9th nerve is glossopharyngeal. 10th is vagus nerve. 11th is spinal accessory. And 12th cranial nerve is. So for today, we're going to look at the first 2 cranial nerve 1, which is the olfactory nerve, and cranial nerve 2, which is the optic nerve. Today we'll look at these 2, and I'm gonna concentrate more on the clinical relevance and what kind of question they like to ask, or what concept they like to test on the USMLE or other board exams. And one more thing I have to mention is that for these cranial nerve, this is specifically for the lab exam at your school. Like, when you're doing anatomy, that's a lab exam, right? So for the lab exam, you have to know the different foramen of the skull, right? Sometime during the lab exam, they're going to tag a foramen, and you have to identify like what foramen this is, and what nerves or structure go through there, and the function of the nerve or the structure. I'll give you an example. Maybe at your school, they're gonna tag let's say foramen rotundum, and you have to be able to identify foramen rotundum, and then you have to say what kind of nerve goes through that, which is do you know what goes through foramen rotundum? Trigeminal nerve, right? V2 of trigeminal nerve. What is V2 of trigeminal nerve? The branch of V2 of trigeminal nerve is maxillary nerve. So the maxillary nerve goes through foramen rotundum, and that's involved in what? Sensation of the face. V2. And so that's kind of thing that you have to know for your lab exam. So know your foramen and know the structure that passes through each foramen, and that's going to be heavily tested during your lab exam. Okay, your cranial nerve 1 is what? Your cranial nerve 1 is olfactory nerve, right? And the olfactory nerve involved in what? Smell. So sensation of smell, sensory, right? So your smell, your smell ability is because of your olfactory nerve, right? And basically, you have your olfactory tract, and the olfactory tract is coming from your olfactory cortex, and the olfactory tract will end in by becoming olfactory bulb, and the olfactory bulb will lie above a structure called the cribriform plate. Cribriform plate is part of your ethmoid bone, and the cribriform plate is important because there's so many little olfactory foramina. So that means that there's so many holes. In your cribriform plate, and that where the olfactory nerve exits your skull. So what happened is you have your olfactory bulb, and with the olfactory bulb, there's going to be so many bundles of fibers that will exit the little holes, the little cribriform foramina. So you have little about 20 bundle of nerve fibers exiting those little olfactory foramina, and that becomes the olfactory neurons, right? And the olfactory neurons, they're kind of like an afferent neuron or an afferent nerve fibers. What does that mean? What does afferent nerve fibers mean? What does that mean? That basically means that the nerve fibers that receive the stimuli from outside of our body, right? So it just means that it receives, like let's say you smell your perfume. You smell perfume, the afferent fibers are the one that carries that sensation to your brain. So I'll give you an example. You smell your perfume. You go to the mall. You smell some kind of perfume. That stimuli, the perfume, will reach your olfactory neurons, right? And once that smell reaches your olfactory neurons, it will move up to synapse with your olfactory bulb, and that signal will move along your olfactory tract into your olfactory cortex, and that's going to give you meaning. It's going to tell that part of your brain that now that, oh, I'm smelling some kind of perfume right now. So that's how it works. So you have your olfactory cortex, olfactory tract, and then olfactory bulb, and then you have your little olfactory neurons which protrude outside of your skull through the little olfactory foramina, which is part of your cribriform plate. And for the lab exam, you have to know and be able to identify cribriform plate, because that's important. That's where these little olfactory neurons exit your skull. An injury to olfactory nerve, injury to cranial nerve 1 will likely result in loss of smell, anosmia, the loss of sensation of smell. And how do we test cranial nerve 1? We usually test the olfactory nerve. Usually, if the patient has some kind of head trauma, or the patient maybe have some kind of anterior fossa fracture, fracture of the ethmoid bone, which the cribriform plate is on the ethmoid bone. So if the patient has some kind of head trauma with fracture of the anterior fossa, or a tumor, if the patient has a tumor in the anterior fossa, we probably would evaluate cranial nerve 1, which is the olfactory nerve. Or if the patient tells you that they've been having trouble distinguishing some smell or something like that, then we would test cranial nerve 1 function. How do we do that? Basically, we tell the patient to close their eyes, and we put a stimuli under their nose, like each nose, one at a time, one nostril at a time. So we might use coffee, close one nose like this, and put some coffee bean underneath the nose of the patient. Have them close their eyes, and they can tell you what they're smelling, and then change to the other nose. Maybe we put soap. We can use soap on the other nose and let the patient tell you what they're smelling. And as I said, usually if there's a fracture, let's say a fracture of the cribriform plate, there will be some kind of nerve damage, because remember that on top of the cribriform plate is the olfactory bulb, and the olfactory neurons will exit those little foramina. So if there's a fracture of the cribriform plate, usually the olfactory nerve will be damaged and destroyed, and the patient will have trouble smelling with their smell sensation. And a good example of olfactory nerve injury is, this is actually kind of funny, because I was watching a Marvel movie over the weekend. I don't know if you guys seen it, the new Marvel movie Black Widow. That's a good example in that movie of olfactory nerve injury. And there's a plot in the movie. I don't want to ruin it for you guys who haven't seen it, but it's a very entertaining movie. There's a plot in the movie that the main character, Scarlett Johansson, for her to be able to assassinate the bad guy, she have to not be able to smell him. So what she does is she purposely injured her olfactory nerve. So you can see in the movie, I think she smashed her head on the table, and I'm guessing that she fractured her cribriform plate. So when she fractured her cribriform plate, she caused an injury to her olfactory nerve, and then she has trouble like smelling the bad guy, and not being able to smell the bad guy allows her to be able to assassinate the bad guy. And it's a very good movie, so I don't want to ruin the plot for you, but that's an example that I just thought of right now about olfactory nerve injury, and it's from the movie Marvel movie Black Widow. Scarlett Johansson purposely injured her olfactory nerve in order to be able to assassinate the bad guy. It's pretty fun. So next is Cranial Nerve 2. What is Cranial Nerve 2? Cranial Nerve 2 is the optic nerve, and the main function of optic nerve is what? It's vision, right? So visual stimuli, and that's a sensory nerve. And one important thing for the lab exam is that you have to know the structure of optic canal. That's where the optic nerve exits your brain, the optic canal. And another structure to know is that it's an artery. Ophthalmic artery also exits the skull through the optic canal with your optic nerve. So know optic canal, know and be able to identify optic canal when you see the skull in the lab exam, and know the important structure that goes through there, which is the optic nerve and also the ophthalmic artery. And so basically you have your eyeballs, and your eyeballs are connected to fibers, to optic nerve fibers, to the fibers that makes up your optic nerve, right? And your optic nerve cross, right? And the point that your optic nerve cross, that is called the optic chiasma. And after that, after the optic chiasma, the tracks come to your primary visual cortex. So basically your optic nerve brings in the stimuli that you see into your brain and gives your brain a meaning of what you're seeing. It's telling your brain what you're seeing, right? And basically you have your eyes, which contains your retinal ganglia, your retinal ganglia in your eyeballs, and which is connected to your optic nerve. And then when the optic nerve cross, that becomes the optic chiasma. And when the optic nerve and after the optic chiasma cross, the tracks becomes the optic tract before it reaches your primary visual cortex. So your eyes, your retinal ganglia, then you have your optic nerve, and then you have your optic chiasma, and then you have your optic tract, and finally the stimuli will reach your primary visual cortex. So that's an important concept about vision that involves your retinal ganglia, that has some clinical relevance that I will explain later, but I will explain a little bit now, so you have a good idea of when I go over the clinical relevance. So your retinal ganglia can be divided into two parts. There's the nasal retina, and there's a temporal retina. So the nasal retina, the section of retina which is like on the medial side of the eyeball. Let's say, okay, there's an eyeball, the medial side. So the medial side of the eyeball, that's the nasal retina, and the temporal retina is the lateral part, the part on the outside of the eyeball. That's the temporal retina. So the medial part of the retina, the nasal retina, they kind of process the visual stimuli coming from the side, right? So the side, peripheral view, the things that you see on the side are processed by the nasal retina, right? And the nasal retina will process the vision that coming from the side, and it will reach the optic nerve, and then it will cross via the optic chiasma, and then the stimuli will end up on the opposite side of your primary visual cortex. So nasal retina process the visual stimuli coming from the side, the peripheral view, and the stimuli will come through your optic nerve, and it will cross, and the stimuli will go to your primary visual cortex, but on the opposite side because it follows a pathway of the chiasma. Now, the temporal retina, that's the lateral part of your eyeball. The temporal retina will process the stimuli that's coming straight at you. So it'll process the visual stimuli coming from the front, right? So the nasal retina process stimuli from the side, temporal retina process stimuli coming from the front, right? Coming from the front, and it processes this through a different pathway than to your nasal retina. The temporal retina will process the stimuli coming that's in front of you, and when it reaches the optic nerve, it doesn't cross. It doesn't cross over your optic chiasma. It just stays on the same side and goes back to your primary visual cortex. So it's both of them are from kind of like different pathways. So nasal retina process the visual stimuli coming from the side, and the stimuli goes to your optic nerve, and it crosses the optic chiasma, while the temporal retina process the visual stimuli coming from the front, and it goes to your optic nerve, but it doesn't cross. It just stays on the same side and goes back to your primary cortex. So one cross and one doesn't cross. So how do you examine cranial nerve 2? How do you examine optic nerve? So you test for visual acuity. How do you do that? So you use the Snellen chart. Have the patient read the Snellen chart for you. So start with the biggest number, and then go progressively smaller, and see if the patient can like read the numbers or read the letters back to you. And then you can test the colors too. See if the patient can distinguish some colors, and that would test them for the color blindness. And then after that, you test visual field. Visual field, basically you're testing nasal. You're testing the patient's nasal retina ability for the patient to see peripheral view, right? So how do you do that? You have the patient cover one of their eye. Tell the patient to look at your nose. Tell the patient to look straight at your nose, and then you would flash numbers through the 4 quadrants. So you flash the 1, 4, 5, or something like that, and see if the patient can distinguish the numbers that you flash to them, like in the 4 quadrant, while the patient looks straight ahead. So the patients look straight ahead, and they see 2, 1, 5, 4. The patient has to be able to like look at that peripheral view and distinguish the numbers. That kind of test the patient's nasal retina, and so you do it with both eyes. Cover one eye and then cover the other, and that's testing visual field. Next, you want to examine the patient's pupillary light reflex. How do you do that? What is pupillary light reflex? Basically, that's when if a lot of light is coming through your eyes, your pupil will constrict to kind of minimize the light coming through your eyes, and so this actually involves 2 cranial nerves: cranial nerve 2, which is the optic nerve, and also the cranial nerve 3, which is oculomotor nerve. So a lot of time your cranial nerve all over the body, your nerves will work together to provide a desired reaction from your body, a desired state of your body. So, your optic nerve or your cranial nerve 2 is involved with your afferent limb of your pupillary light reflex, and your cranial nerve 3, the oculomotor, is involved with afferent limb of your pupillary light reflex. What does that mean? The afferent limb of the pupillary light reflex basically means that your eye is sensing so much light. It's just like sensing so much light that's coming into your eye, and your cranial nerve 2 is telling your brain there's a lot of light, right? So afferent limb, it's kind of like being telling your brain that a lot of light is coming through, and afferent limb, it's kind of like a reaction. Usually it'll be a motor reaction. So so basically cranial nerve 3 is involved with afferent limb, so that's a reaction, right? Cranial nerve 2 basically saying a lot of light is coming through. Cranial nerve 3 is basically saying that, okay, we understand now a lot of light is coming through, so we're going to send a signal back to your pupil to constrict. So basically cranial nerve 2, which is the optic nerve, will tell the brain a lot of light is coming through, and then cranial nerve 3 will make a response of making your pupil constrict. So cranial nerve 3 will be involved with the motor reaction through because of that so much light coming in. And we'll talk more about oculomotor nerve, cranial nerve 3 in our next video. But so how do you test the pupillary light reflex? You get a pen light, and you want to flash into your patient's eye and check the pupil response. So you get a pen light, flash into the patient's eye, and the pupil should constrict. And you should look at the other side too, because the pupil should constrict bilaterally, right? So you shine the light through this eye, then you look at this eye, and when this eye constrict, the pupil in this eye should constrict also. That's pupillary light reflex. So what kind of question do they like to test with the cranial nerve to the optic nerve injury on your body exam? They like to test tunnel vision with optic chiasma injury. So they like to test that somebody has pituitary tumor, and that causes temporal field blindness. So it causes patient to have tunnel vision. And on the question stem, you might see something like a patient driving, and they change lane and crash into the car next to them because they couldn't see the car next to them because they have bitemporal blindness. So they change lane and then just merge into the car next to them. And they did an MRI scan, and they will find that the patient has pituitary tumor pressing on the optic chiasma. And how does that work? Like why does the patient have tunnel vision with pituitary adenoma pressing on the optic chiasma? And remember, the pituitary gland is right underneath the optic chiasma. So you have the optic chiasma right here. Underneath it is your pituitary gland. So if you have pituitary tumor like pituitary adenoma, and the tumor grows bigger, and it will hit directly onto the optic chiasma. And now remember my explanation before that your nasal retina process the visual stimuli coming from the side, the peripheral view, and your temporal retina process the vision directly in front of you, right? And remember the stimuli coming from the side, which is processed by your nasal retina, the pathway they cross with the optic chiasma, while the view from the front, which is processed by temporal retina, they don't cross, they don't go through the optic chiasma, right? So you have your optic chiasma and you have your tumor underneath pressing on the optic chiasma. So which stimuli is it gonna affect? It's gonna affect the one that cross, right? And which stimuli cross? The stimuli that's being processed by the nasal retina, right? Which is the stimuli of the vision coming from the peripheral view, the vision coming from the side. So that's gonna be compromised, right? So the patient will not be able to see the stimuli that's on the side, the peripheral view, because that's a tumor pressing on the optic chiasma. But the vision from the front, the stimuli coming from the front, that doesn't cross, right? That's not affected by the tumor at all. So because it doesn't cross the optic chiasma. So this is the reason that the temporal retina is still able to process the information or the visual stimuli coming from the front, but the nasal retina is not able to process the visual stimuli coming from the side properly, because that's a tumor obstructing the optic chiasma, and that's the reason that the patient will see tunnel vision. And another concept about vision is optic tract injury. So if you have left optic tract injury, your right eye would have would have vision problem, and if you have right optic tract injury, your left eye would have some kind of vision problem. So it's always opposite with your optic tract injury. And remember, you have your optic nerve out front, your optic chiasma, and then you have your optic tract behind. So right optic tract injury, left eye blindness. Right optic tract injury, right eye blindness. So we talk a lot today about Cranial Nerve I and Cranial Nerve II, olfactory nerve, and the optic nerve. So the next Tutor review, we will talk more about cranial nerves, and we'll concentrate more on the clinical relevance of what you're going to face in your board exam. And I hope you learned something today, or I hope this was a good review. Don't forget to do your Q banks and do your NBME exam, practice exam also. I'm Dr. Chuck with CMC. See you next time. สวัสดีครับ